I was hoping you could give us an update about the Spotlight results, trial results that were presented, but maybe to start, maybe just set the stage as to what the trial design was and what the drug is.
Sure. Well, we're obviously in search of new targets for new drug development. And claudin 18.2 is a gap junction protein that's preferentially expressed in the stomach, and particularly in gastric and GE junction adenocarcinomas. And Zolbetuximab is a monoclonal antibody that targets this pathway, and it may lead to immune cell recruitment, specifically stimulating ADCC and complement-dependent cytotoxicity. So a prior study done in gastric cancer was a randomized phase 2, which showed very encouraging results, response rate, survival, PFS improvements when this drug was added to chemotherapy compared to chemotherapy alone, particularly in patients that were high expressors of claudin 18.2. And even though probably 80 to 90% of these cancers express claudin 18.2, about 30 to 40% are high expressors, so that would be 75% or more. So based on this, this led to the development of two randomized trials. One was Spotlight, which was a randomized placebo-controlled trial adding Zolbetuximab to FOLFOX. At that time, immunotherapy was not part of standard first-line treatment. And then the other trial was a similar design, capecitabine oxaliplatin, with or without Zolbetuximab. So Spotlight, both Spotlight and GLOW have been published. They're both positive trials. Spotlight did indicate significant improvements in survival, about a 2-month improvement in median overall survival, and the hazard ratio was above 0.7. And also there were improvements in progression-free survival, also about 2 months. Even though response rate was similar, the tail on the curve for duration of response was higher for the Zolbetuximab arm. And toxicity was manageable. I mean, because there is off-target effect in the stomach, nausea and vomiting was an issue. But if it was treated appropriately beyond the first cycle, it was usually not an issue. But that's a class effect for these antibodies that target this pathway. So Spotlight was updated this year by Dr. Shatara, and basically the results hold up. Again, we see this 2-month improvement in median overall survival, 2-month improvement in progression-free survival. Even though the response rates are similar, there is a greater duration of response for Zolbetuximab. And what's exciting is there's a tail on the curve beyond 2 or 3 years, which we see in immunotherapy trials. So I think some patients achieved lasting benefits from addition of this drug, and it does represent a novel immunotherapy. And the GLOW trial came to very similar conclusions in terms of improvements in progression-free and overall survival. Similarly, although there wasn't an enhancement in response, the duration of response was longer with Zolbetuximab. So this drug is awaiting imminent approval. There were some production facility issues, but this drug will emerge as an option in first-line treatment in metastatic gastric, esophagogastric cancers that overexpress claudin 18.2.
Yeah, thank you so much. Great summary, and it's exciting to see more and more targeted therapies entering first-line space. But I think it'll be a challenge for us to decide how to pick the right agent when there is an overlap in biomarkers. Do you have any thoughts on future incorporation or combination strategies?
Well, there is an ongoing phase 2 that's combining checkpoint inhibitor therapy with Zolbetuximab and first-line chemotherapy. And in a retrospective analysis of the patient data and tissue, it turned out only about 13% were strongly PD-L1 positive. So most of the patients were PD-L1 low or negative that were enrolled on this trial. So Zolbetuximab arguably could target patients that are PD-L1 low or negative that wouldn't be candidates for immune checkpoint inhibitor therapy. But obviously, these trials validate claudin 18.2 as a viable target, and there's a host of drugs in development, antibody-drug conjugates that target claudin 18.2, bispecific antibodies that combine in another immunostimulatory domain with anti-claudin 18.2, and even cell-based immunotherapy. There are a number of CAR T-cell programs underway. Some preliminary data from one of the Chinese studies showed a pretty substantial response rate in the 40 to 50% range. So clearly demonstrating activity. The duration of responses were not that long, but this is a pathway that is a subject of huge drug development with many novel classes of agents. And the drug itself, as a single agent, doesn't seem to have that much activity, but certainly combining it with chemotherapy and these novel bispecifics and antibody drug conjugates are an exciting area of new drug development. And of course, we would love to see novel agents that target, because it's such a commonly overexpressed marker in gastric cancer. This is a drug that merits evaluation in the neoadjuvant space.
Oh, I absolutely agree. There are so many agents in development that target claudin. We know it's a real biomarker in this disease. And I actually think that if any of the targeted agents, including immunotherapy, were to move into a perioperative space, that would also help us figure out what to use in first-line setting if there were a recurrence.